Hello everyone. Hello everyone. I'm Anas Al Ubaidi, and the topic for this session or this lecture is integrated patient cases, gastrointestinal, GI, and renal disorders. This session or this lecture is within chapter 30 of the review of gastroenterology and nephrology, scribing, within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Integrated patient care involves understanding and documenting how multiple organ systems interconnect to influence a patient's overall health. For medical scribes, mastering the interplay between GI, gastrointestinal, and renal disorders is critical. These two organ systems share several physiological pathways, including fluid and electrolyte balance, metabolic regulation, and excretion of waste products. Ineffective documentation of cases where these systems overlap can lead to misdiagnoses or suboptimal treatment plans. Gastrointestinal GI disorders such as inflammatory bowel disease (IBD), which includes Crohn's disease (CD) and UC ulcerative colitis, liver failure, or GI bleeding, gastrointestinal bleeding, frequently affect renal function, kidney function through mechanisms like dehydration, metabolic disturbances, and medication-induced nephrotoxicity. Conversely, impaired renal function can present GI-related symptoms such as nausea, abdominal pain, or altered bowel habits due to build-up of toxins or imbalances in electrolytes. Recognizing these cross-system impacts is essential for holistic patient care. Key points. Importance of integrated documentation for GI and renal disorders. We'll start with patient complexity. Patients presenting with GI and renal disorders often experience overlapping symptoms and multifaceted complications. For instance, for example, someone with Crohn's disease (CD) complicated by renal stones may exhibit symptoms that overlap, for example, abdominal pain, but have distinct underlying causes. Accurate documentation ensures the care team differentiates and addresses these problems. Impact of medications. Treatments for GI conditions may exacerbate renal issues, and vice versa. For example, NSAIDs, non-steroidal anti-inflammatory drugs used for controlling pain in inflammatory bowel disease, can worsen renal function. Diuretics prescribed in renal disease can contribute to dehydration and lead to worsening of GI symptoms like constipation. Medical scribes must document not just prescribed medications but also any side effects or unintended impacts that they may have on the other organ system. And here's a diagram summarizing the integrated documentation challenges. Shared pathophysiology. GI and renal systems are closely linked through water and electrolyte balance. Severe vomiting or diarrhea from GI conditions can lead to acute kidney injury, AKI for short, due to fluid depletion. Renal disorders such as chronic kidney disease (CKD) often manifest as GI symptoms, including nausea, vomiting, or uremic gastritis, making it imperative to record potential red flags for multi-system involvement accurately. Continuity of care. Integrated documentation ensures no key details are missed between providers managing GI, gastrointestinal, and renal or kidney conditions. And nephrologists may need to know the patient's current bowel habits, while a gastroenterologist benefits from understanding renal kidney clearance for safe medication prescription. Scribes create the bridge by providing comprehensive notes that capture all critical information. And here's a diagram summarizing the interconnectedness of GI, gastrointestinal, and renal health. Documentation of patient history in integrated scenarios. Detailed history of present illness, HPI. Key points for GI disorders: record specifics such as abdominal pain, location, onset type, and associated symptoms like nausea or heartburn. Changes in bowel habits, blood or mucus on stool, vomiting or jaundice. Key points for renal disorders include urinary symptoms, for example, hematuria, blood in the urine, or low urine output. Swelling indicative fluid of a fluid retention, fatigue or flank pain. Integrated perspective: document any sequence of events linking GI, gastrointestinal, and renal symptoms. For example, patient reports recurrent vomiting after a bowel obstruction followed by reduced urine output and uh, lower extremity swelling within 48 hours. And here is a diagram summarizing the key points for medical disorders. Systems review and risk and identification. Ask about prior conditions affecting both systems. Chronic conditions, for example, chronic kidney disease, CKD, CD, Crohn's disease, or cirrhosis. Lifestyle habits like high protein diet, risk of kidney stone formation, or alcohol use, GI bleeding/liver damage. Document risk factors such as long-term non-steroidal anti-inflammatory drug or laxative use, recent antibiotic regimens, risk for Clostridioides difficile or Clostridium difficile infection contributing to dehydration and renal injury. Example: a patient with a history of ulcerative colitis (UC) comes in with loose stools for 2 weeks. Review includes recent use of diuretics like worsening dehydration and kidney function. Diagnostic testing in integrated cases. A lab laboratory workup, GI disorders, stool analysis, for example, occult blood pathogens, liver function tests, ALT, AST, bilirubin in suspected liver disease, renal disorders, serum electrolyte levels, hyponatremia, hyperkalemia, and CKD, chronic kidney disease, urine analysis, proteinuria or hematuria and glomerulonephritis. Integration here: document interplay findings like elevated creatinine levels with concurrent hyperkalemia due to diarrhea-induced dehydration, hypoalbuminemia from malnutrition, and severe Crohn's impacting renal function or kidney function. Imaging and procedures: GI imaging, document findings from endoscopies, for example, reveals ulcers, and CT for bowel inflammation. Renal imaging include ultrasound or CT findings for obstructions, hydronephrosis, or stones. Integration: note findings indicating cross-system impact. For example, a renal ultrasound, kidney ultrasound might show nephrocalcinosis connected to chronic diarrhea and electrolyte loss. Example: a dehydrated patient with chronic diarrhea has a CT abdomen showing colitis and elevated creatinine levels, indicative of a pre-renal AKI, acute kidney injury. Treatment planning and follow-up care, integrated treatment documentation, GI medications like proton pump inhibitors, PPIs, biologics, antidiarrheals, or stool softeners, renal prescribed diuretics, antihypertensives, or phosphate binders. Integration: record treatments collaboratively, noting contraindications, for instance, avoiding nonsteroidal anti-inflammatory drugs and SAIDs in Crohn's disease (CD), patients with chronic kidney disease, ensuring IV hydration in cases of GI-related AKI, acute kidney injury. Nutritional management: document specific diet tailored to both systems. GI cases may require gluten-free, low-fat plans. Renal diets focus on restricting potassium, sodium, or phosphate. Combined tactics: a patient with inflammatory bowel disease and chronic kidney disease (CKD) might necessitate a low-fiber, low-potassium diet tailored to their current symptoms and labs. Long-term monitoring, note the necessity of regular follow-ups. GI cases require lab monitoring for ongoing inflammation, bleeding, or organ damage. Renal follow-ups include electrolytes, glomerular filtration rate, GFR, and urine analysis tracking. Example, the medical note should specify that the patient prescribes steroids for inflammatory bowel disease, IBD, requires serum glucose monitoring to prevent chronic kidney disease exacerbation, CKD exacerbation. Summary tables next. Table here we have a table on overlapping symptoms of GI and renal disorders. Table on key diagnostic tests in GI and renal disorders. Table on common treatments for GI and renal disorders. Table on nutritional considerations for GI and renal disorders. Table on follow-up and monitoring for GI and renal care. Then we will revise what we have covered through this lecture via some MCQs or multiple choice questions. Question 1. Which of the following symptoms is commonly shared by both GI and renal disorders? Is it hematuria, blood in the urine, A, B, jaundice, C, nausea and vomiting, or D, fever? Nausea and vomiting, C is the answer, as nausea and vomiting both are common symptoms that can arise from GI disorders like bowel obstruction and renal disorders such as uremia. Hematuria is more specific to renal issues, jaundice is linked to liver dysfunction, and fever is associated with infections rather than systemic GI and renal effects. Question 2. What lab test is most useful for assessing a shared impact of dehydration in GI and renal disorders? Is it A, liver function test, B, serum electrolytes, B, C, urine analysis, or D, stool analysis? B is the answer, serum electrolytes. As serum electrolyte levels can reveal imbalance caused by vomiting or diarrhea, GI focus that may lead to acute kidney injury, aka renal focused. Both liver function test, LFT, and stool analysis are specific to GI conditions, while urine analysis is more renal specific. Question 3. A patient with Crohn's disease CD and chronic kidney disease CKD presents with worsening abdominal pain, diarrhea, and edema. What symptom connection should the medical scribe emphasize in their documentation? A. Dehydration from diarrhea could increase uremic symptoms. B. Abdominal pain is unrelated to renal function. C. Edema is caused solely by chronic kidney disease. Or D. Both conditions require unrelated treatments. So the answer here would be A. Dehydration from diarrhea could increase uremic symptoms, as Crohn's associated diarrhea can lead to significant fluid losses, exacerbating kidney dysfunction and uremic symptoms in CKD. Abdominal pain, often tied to GI inflammation, may be indirectly connected to systemic fluid imbalance. Question 4. Which imaging test is most appropriate when evaluating both GI and renal complications in a single patient? A. Abdominal CT scan. B. Colonoscopy. C. Renal or kidney ultrasound. Or D. pH monitoring. So the answer is A. CT scan, as abdominal CT allows simultaneous evaluation of bowel structures for obstruction or inflammation, GI, and visualization of kidneys for hydronephrosis or stones, renal. Colonoscopy only assesses GI specifics. Renal ultrasounds are renal specific, and pH monitoring is related to acid reflux. Question 5. Which dietary adjustment should be recommended for a patient with inflammatory bowel disease and chronic kidney disease, CKD? A. High potassium diet with increased fibers. B. Low potassium, low fiber diet. C. High protein diet to support tissue healing. Or D. Low calcium diet to prevent hypercalcemia. So we read this one during the lecture, during the session, within the slides, and the answer is B. Low potassium, low fiber diet, as this diet addresses both systems effectively. Low potassium is essential to manage hyperkalemia risks in CKD, while low fiber minimizes GI stress during active inflammatory bowel disease. High protein or low calcium diets are specific to other conditions and could pose risks in this case. And here we come to the end of this lecture. Thank you very much, and goodbye.